we've heard a lot already. I mean, we started with Semmelweis and Hamilton and the $6 million man. But we're in this space of the deployment, the adoption. How do we sort of unleash and get this thing moving forward? And we heard a little bit about the tipping point as well. And I'm as Jill knows, a big Malcolm Gladwell fan. He wrote about the tipping point in 2000 and again in 2024 on Revenge of the Tipping Point. So we've got to think about all of the things, all the obstacles and all the components that we need to address and consider to get to that tipping point and unleash this adoption. So I'm going to ask each of you to, again, tell us a little bit about what you do, but tell us how you're looking at this and the things that we should be considering.
Well, Murthy Savambatla, Setpoint Medical. I've been with the company about 7 years now. It's been quite a journey. Now, getting ready to launch a new therapy doesn't begin the day you have FDA approval. This has been something we've been working on for about 5 to 7 years. It all starts with, what is the unmet need? Kevin, Tracy, and others touched upon them. These drugs are really helpful to patients, particularly in protecting the joints, preventing disability, offering symptomatic relief, but there's a lot of issues. They come with black box warnings. There's issues with compliance and therapy persistence. The cost of the system is immense. We spend about $100 billion a year on autoimmune drugs in the US. There's a lot of pressure on the Medicare Trust Fund. So can we really address all of that with this therapy? So that's a key question. And then you set up the programs to try to answer these questions, starting with a big randomized pivotal trial to in fact show that you can help patients protect the joints and do it safely. Now, a big question on our mind was the health economics, because that is something you need to have ready at the time you're launching. And we, in fact, set up a clinical trial to answer those key questions on health economics. And you've got to do that right from the get-go. It's very difficult to look at it retrospectively and do that analysis. And even in our early studies, it became pretty apparent that we could potentially save the healthcare system a lot of money if we were able to show the reduction of drug utilization in conjunction with our therapy. And we began work in earnest with payers a few years prior to launch, both private insurers and CMS. CMS, in fact, asked us if we wanted feedback on our clinical trial design, and we said, yes, please. And we incorporated that. Yeah. Now, just because you have all of these things doesn't mean your therapy is going to start soaring right away. And there's a lot of things to work through. The best way that I like to think about this is you got tremendous tailwinds supporting this therapy. You got a boat, but unless you erect the sails, you're not going to catch these tailwinds. So the early launch is somewhat thoughtful. We got to think about reimbursement. We got to think about patient workflow. The referral pathway between a rheumatologist and an implanting neurosurgeon doesn't exist today. You got to work with Medicare. You got to work with private payers. So the best approach in a situation like this is to launch it thoughtfully, initially, learn from that, iterate your playbook quickly, because it's very difficult to learn and very expensive to learn and innovate and iterate at scale. So you've got to do that in a small microcosm of the country, learn from that experience, and then scale. And that's kind of the stage we're at right now.
Thanks. Ami, you have a special focus with your work on the FDA Advisory Committee.
Yeah.
Tell us, what's your perspective?
Yeah, so I'm going to do 3 hats really quickly because I wear all 3 of them. The first thing I'm going to say is I call myself a boots-on-the-ground cardiologist. This is a boots-on-the-ground entrepreneur, right, who's in it every day living, and you can hear it the way he just lays the groundwork for you of FDA approval is only the beginning. And if it is, in fact, just your beginning of thinking of deployment, then you're already probably one of those who's not going to make it. And so first of all, kudos to you. I'll start with that cardiology hat for a second. As a cardiologist and researcher for many years, I never thought that working on the JAK-STAT pathway would bring me here today, sitting next to you with a device, right? So we don't even think about the relationship sometimes between that bench science when we're training and what it could be I think medical schools like Northwell are starting to teach people to think that way, and so the next generation needs to start learning that way, so it's not a surprise to them like it was to our generation. I'll move to Chief Innovation Officer at the American College of Cardiology for a moment to say that one of the most important things that we have learned in cardiology is that once you're starting to tip those scales, you need societies, you need patient advocacy organizations, you need actual advocacy at the congressional level, that version of support to be able to scale. Because people need to know what you can do, and it needs to be from someone who is not your company marketing yourself. And so you need your believers to speak with you. At the same time, you need to teach all the clinicians in health systems who are heads down, doing their daily job and do not have time for the newest, latest device. It is a little exhausting when you're in practice, when every disease you treat has a new potential thing. You can't work through it. So you need these groups to come and say, hey, this is where it fits. This is a new tool in your toolbox. We're not asking you to change everything. We're saying, for some patients, this is going to be the right way to do things. And so I think that's really important. Now I'll move to the FDA. I'm not speaking for the United States government. However, one of the most important things about the Digital Health Advisory Committee, and I also work with TAP, which is a program that works with breakthrough device design at the FDA, is that we meet with people kind of early and often, thinking about not how to regulate their technology, thinking about what is the infrastructure they need for growth that has guardrails. So really, the FDA is meant to be infrastructure with guardrails. And if that's how you approach companies that are now getting approval and coming in, then you have the opportunities to say, what are the things that are potentially holding us back? For example, in a drug, you say all these side effects. In a device, you say, what if things change? What does continuous monitoring look like? How often does continuous monitoring need to be done? Who's on the receiving end of how your device is doing? Is it the patient? Is it a clinician? Is there a system intervening in between that? So that post-implementation metrics and monitoring, that's our equivalent, if you will, of side effects. We have to make sure that we're measuring for those things. And so that's kind of where we're going with the FDA. What we want to see is more than 10% of FDA-approved devices make it to market. And right now, we're not really there yet. So we have a lot of work to do, but we're excited to do it together.
Lonnie, as a clinician, chief medical officer, entrepreneur, and someone who's launched multiple companies, give us the formula.
Okay, I'd be pleased to. So one sort of initial comment, I'm pleased and sort of impressed that there were 2 cardiologists out of 5 panelists speaking on a panel about neuroimmunology, neurobiology, and collagen vascular disease. And there's something sort of encouraging about that because it represents, I think, a convergence of disciplines. And I think the convergent area is inflammation. And I think once we begin to crosstalk and connect, we'll make some significant advances. So I'm pleased about the composition of this panel. A couple other comments, things that worry me because I love the technology. I'm excited by it. I devoured the book. So what are some of the obstacles? I'm going to reflect back on my time at Aetna a little bit. The first, which I think has already been mentioned, is FDA approval is almost a Pyrrhic victory as you think about the implications for coverage. Because it's approved doesn't mean it's going to be covered, and because it's covered doesn't mean that patients' say out-of-pocket costs aren't going to be excessive. So let's be real about diffusion and barriers and the very, very significant journey that needs to occur and the issues that need to be addressed before there's wide accessibility. So the insurance issues, I think, are of considerable importance. The other point I'll make relates to what I've really devoted my career to, and that in large part is about clinical inertia and patient inertia. So we've all been trained to do what we do. We've all had mentors. We all have sort of the blue plate specialist to how you treat rheumatoid arthritis or atherosclerosis. It's hard to change. And if you think about incontrovertible standards in medicine, and you know this better than me, look at heart failure. very, very effective therapies for certain types of heart failure. They're not used. Maybe 10% of patients get quadruple therapy, 1% maybe get the right dosage. So for things that are established, we're just doing a horrible job. And when we think about something new, in the context of some of the issues that have been raised with regard to barriers, we have a lot to do. I think information technology, data as the new currency for advancement of these exciting issues and opportunities is important, but it's going to be a tough road to hoe, and I think it's important to also understand that there's no end to what's going to be required. We need longitudinal data, we need real-world evidence, and we're going to be challenged forever to prove the efficacy, cost-effectiveness of this, and hopefully we'll even establish a point where we've established the cost-saving nature of this, which is very, very different than cost-effectiveness.
Ami.
I was feeling good about myself, and then you start talking about heart failure, and now I'm not. I think it brings up a really great point, though, which is what we're struggling with in heart failure. And by the way, there is a lot of evidence for the vagal nerve in heart failure. We just changed our guidelines to say inflammatory markers should be checked in everybody with a risk of heart disease. So we're very aligned clinically. But let's go back to this idea of bioelectronics and why. Chronic disease management is the bulk of what we are doing across all of our disciplines, and it happens in the communities where people live. And we're moving to a point where now, with implantable devices like this, we can actually start to put more agency into the community, whether that's into a patient's hands or whether that's into people in local communities, such that when you see that rising risk when things are changing, you can now change things and get them back to baseline in the community where they live. It means, I think this is a pyramid, which is why I'm making awkward movements with my hand. But here's chronic disease management, here's rising risk where we're gonna catch people and bring them back down. And then up here is this high resource utilization. Aetna's like, why do these patients cause this much money, right? That's up here. What we've been doing with technologies is saying the tertiary, quaternary level people are the ones who best understand the technology. Therefore, they will enact it. And we will, I think, not get anywhere doing that. And so I think empowering people along the whole spectrum from community to tertiary to say this is what the device is, this is how it works, and this is how a patient-clinician partnership works with these devices, I think that's where this field is taking us. And so I do think that shift is important. Otherwise, we will end up where we were with heart failure, which, by the way, I also want to move heart failure in that direction. We'll get there.
We'll get there, right?
Murthy, let me throw this at you. I mean, this is not your first rodeo. You've been through this with others, in particular with the stents. Are there certain things that we should really be careful not to do with respect to mistakes you've seen in the past?
That's a great question.
Yeah, I think, look, everything we do is on a foundation of level 1 clinical evidence. And you've really got to stick to that. You've got to be hyper-focused on what types of patients would benefit most from this therapy in the early years. You've got to be very focused on what types of rheumatologists you want to call on at the beginning of this journey. There's 5,000 plus rheumatologists in this country. And the biggest mistake you can make is go everywhere all at once. It's going to be frightfully expensive. It's going to be chaotic. So doing it somewhat thoughtfully is probably the greatest lesson learned over time. Now, I will add, we've spoken a lot about challenges, but we're here because of the opportunities. And nothing big in medicine happens without challenges. But in my view, given the nature of these challenges, whether it's reimbursement or changing medical practice, you got to have a big idea so it makes it worth it. To invest your time and energy in the trials, in commercialization, to realize a market at the other end that's large enough and millions of patients to benefit over time, that's what makes it worth it. And the reason I'm a bit optimistic, while acknowledging all of these barriers ahead of us, is unlike, say, heart failure, where a lot of decisions are made at a hospital. The dynamic is completely different in rheumatoid arthritis. Right. The typical onset age is 30 to 50 years. So it's not necessarily a condition that affects just the elderly. These patients are very active in terms of supporting each other. It's about 80% female, very active in terms of looking for solutions for the treatment. They're very concerned about immunosuppression. They're very concerned about the side effects, the intrusion into the quality of life. So this is a therapy that I think is going to get pulled by patients. It's not one, unlike some other medical device therapies where patients get scared away. We've heard about some of these. This is quite the opposite, where we've seen tremendous pull from the patient. So that's important. We've got to reach out to the patient. But I think there's also a lot of openness amongst rheumatologists. It started off with a lot of skepticism, but once you have FDA approval, once you have level 1 evidence, your engagement with rheumatologists starts to change. And most rheumatologists practice in the community. They have their own sets of challenges with drugs, like prior authorizations. It's not just a device issue. These physicians are stuck doing prior authorizations every time the drug is switched. Working with insurance companies, going back and forth. They've got to do annual reauthorizations, even if the drug isn't changed. I think we can provide relief on many of those levels to physicians and not just patients. And that's a process of education. And we do that at multiple levels. At the level of the society, we engage at the conferences. At the level of major hospital systems, our chief medical officer is out there engaging them in these conversations. But importantly, at the level of the community rheumatologist. So getting that groundswell of support, it takes time, but that's where a lot of our focus is. I'll just say one more thing on payers. Rheumatology, just given the age of patients, is about 50-50, private insurance and Medicare. And we've had something unusual happen to us in that we've had Medicare contractors reach out to us, which is somewhat unusual, just given the tremendous pressure of the cost of these drugs on the trust fund. So like I said before, we have tailwinds. Yes, there are challenges, but by thoughtfully engaging with the patient, with the physician, with payers, I believe we'll make progress.
Yeah, Lonnie, let me ask you a question, maybe to everyone. We talked about rheumatologists, neurosurgeons getting together, as Kevin said, unusual relationship. But isn't it more important or equally important that the entire physician and academic community understand that this is a therapy that will have something to do with every single disease that everybody treats someday? Because for the first time, although we've thought about it for eons, that the brain is really controlling everything, no one could figure out how. And everybody needs to buy into this, because if a rheumatologist and a neurosurgeon says this is the way, and then you look at and you go to your generalist or somebody else and they're like, it sounds crazy to me, that's not going to work. How do we get throughout the entire physician community?
Right, so I was about to say, regrettably, we haven't talked about primary care yet. You just brought it up, so thank you. But what is the role of the primary care physician in all of this? And part of it relates to knowledge diffusion. How do we educate primary care physicians as well as other types of physicians? How do we exploit the data that we have access to and create a bridge between the existence of these capabilities and the person on the street who will in fact benefit from those sorts of interventions? So I think the entire community, including the patients, need to be aware. I'm actually struck, particularly, by the power of stories. In Kevin's book, there are descriptions of patients. We met some of the patients. It's quite moving. And if I may, I'll talk about myself. And many of you know that I've been sick for about a year. I'm better now. But I was cognitively impaired rather severely, objectively, and you could also ask my wife. And I think, well, I'll leave it to you to judge whether or not I've improved. But I've been the beneficiary of the sorts of advancements that we're talking about. And the other issue, that I'd like to bring up is health equity. If I were not me, with the knowledge I have, the experience I've had, with the friends I have and the resources I have, do I have the privilege of sitting in front of all of you today as opposed to maybe being somewhere else where objectively, forget about objectively, I couldn't name my 3 kids a year and a half ago. So we really need to create a mechanism for diffusion of knowledge, information, acceleration of adoption, and now speaking personally, it just couldn't be more important.
No, terrific. Ami, so are we ever going to get to the point now where it's like patients on the street talk about stents like they're proud of how many they have, so.
Oh gosh, that's the opposite direction of cardiovascular prevention, but okay.
Just go to Katz's Deli, by the way.
No, I'm gonna double down on optimism, actually, with that, which is I came from the health conference where we were talking about women's health. And it struck me as you said this, rheumatoid arthritis, 80% women. And this is a novel device changing the way we do things. And it is going to be in this population. I will also then extend, though, and say heart disease, #1 killer of women, and in fact, very closely tied to those who have inflammatory disorders, including rheumatoid arthritis. And so I think one way to tell that story is to sometimes have people see their relationship as closely as they can to what we're working on, because we can't work on something with every disease at once. I would love for you to, but you need to focus. And as you're focusing, we can still tell the story of, as we improve these women's health, the likelihood of their having a cardiac event is absolutely going to decrease, and we can help you measure that and spread that knowledge. So I think that relationship is really important for us to do moving forward.
So a few last words. We've just got about 2 or 3 minutes left. Murthy, tell us, what is the #1 thing we should be doing?
The #1 thing we should be doing is investing in education and getting the word out. Because this is so new, this isn't even taught in medical school yet, it probably won't be for a few years, and we can't do it alone. So we got to partner with hospital systems, with physician societies, with patient advocacy groups. So there's a lot of work ahead of us, but it's primarily in the realm of education and raising awareness. And that, I think, is going to be key to get this to ramp the way we want it to ramp.
Terrific. Ami, same thing. #1 thing.
I think the #1 thing we can do is start to create an infrastructure for better care in the areas that just have no access right now. We do a lot more care in areas that have access, and we're still leaving large parts of the country and the globe untouched. So if we can start to create some infrastructure, and probably the best thing to do that is to do some upskilling. There's a lot of technology. We didn't really talk about AI, digital health, monitoring, what we can do. But if we can start upskilling people in the community to understand sick from not sick, basic triage better, getting them to access to care, I think we're going to make a huge difference in that pyramid. And I think we're really going to reach people that weren't reached before. And this is a perfect technology to start thinking about for that.
Lonnie?
I think define the opportunity. What is the true total addressable market? And once we've defined the opportunity, talk about impact, the impact on patients, which we've discussed already, and have a very realistic and honest discussion about the economics. So how does it all work with regard to offsets from drug costs? I think we need to address the issue of churn, where patients, the notion that, well, this patient's going to be gone in a year. I think that's exaggerated. People who are sick can't afford to leave their jobs, notwithstanding some issues, and improvements that have been made. But people are going to stick where they're getting their insurance and get care, and they're going to stick around. And then the last point, it's not just the insurers, it's also, and this is an opportunity, the self-funded employers who pay the claims. They also care about productivity. They care about their employees. It's not sentimental. And if they understand the benefits, not only as it relates to the immediate diseases that we're talking about, but the consequences of inflammation and the impact on other organs and other systems, I think there's real opportunity to not only motivate the public, but the people who are employing some of these patients.
Well, again, I'd like to thank everyone. And what I look at in terms of optimism is how do you sort of fit this to the current culture? And I do believe that there is a mindset in this culture who wants to believe in the mind-body interaction. And I think Kevin has proven that. So Congratulations, and thanks, everybody.
Thank you.